So I had been asked to talk about the patient-reported outcomes, but I think I've just taken the liberty to change the topic because I wanted to speak about the entire spectrum of HR positive and HER2 negative metastatic breast cancer, especially about what happens after the CDK4/6 inhibitors were over. So when I first read the topic, my first reactions actually over there was this. I mean, this exactly is a hormonal positive CA breast, and this is tamoxifen with them. This is AIs with the HR positive metastatic CA breast, and then you have a CDK4/6 inhibitors, and then this girl wants more. So, you already have tamoxifen, you have AIs, you have CDK4%, now you want alpelisib also. My subsequent reactions when I looked at this topic basically was the last statement over here that only 30% or 40% of the patients remain progression-free on treatment 2.2 years after initiating the treatment and a CDK4/6 inhibitor. So yes, we have made progress in hormone-positive CA breast, but a lot needs to be done. So definitely you have got a point. Definitely there's a space for newer agents in a hormone-positive CA breast. My second subsequent reaction was that the honeymoon is over. So in short, the SOLAR trial actually starts after the honeymoon with the first line ET, that is the Mona Lisa or the Monarch or the Paloma trial actually ends. So let's talk about the PIK3CA pathway in breast cancer. And I'll start with my 6 basic questions about who, what, where, why, and how. So let's start with what exactly is a PI3K pathway in HR positive breast cancer. So if there are any residents listening over there, basically PI3K mTOR pathway is frequently altered in metastatic CA breast. It basically leads, because of the PIK3CA mutation, it leads to hyperactivation of PI3K pathway. Is it important or not? It is very important. It is actually 40% of the patients actually have a PIK3CA mutation, which will lead to a hyperactivation of the path and following more growth and anti-angiogenesis inhibited. So that is why it is very, very important. Now, what is the prognostic role of PIK3CA mutations? Basically, people who had PIK3CA mutation did worse than what people who did not have. It was 19.36 versus 23.5 months. So definitely it is a very, very, very clinically important mutation that is there. So now, 40% of people get a PIK3CA mutation. The answer is simple. Just block it. It's very, very easy. We all have smartphones with us. You don't like a number, you block it. Unfortunately, it has never been a smooth ride all over. What we imagine our plan to be PIK3CA is like you want to go in a straight line. But in reality, your plan is compounded by multiple crests and troughs. So I'll talk about the downs first, and then I'll go about the ups later. So PIK3CA inhibition is not something, the PI3K inhibition is not something which has come overnight. Novartis has got a drug right now, but that doesn't mean that this drug was, or the strategies to prevent PIK3CA was not before. It was all there. You initially had a pan PI3K inhibitors, then you had a dual pan PI3K mTOR inhibitors, and now you have an isoform specific inhibitors. So finally, initially you were trying to block the entire PI3K, then you started blocking the dual pan PI3K mTOR, and now you basically block the isoform specific PI3K. Now this was the first agent, that was the buparlisib, and this buparlisib plus fulvestrant was compared against placebo plus persistent as the BELE-2 trial, and this trial did not show any advantage. So the first generation failed, the second generation failed, and the third generation is basically alpelisib. So what is the solution? Let's be more specific. So from a class 1 generation of pan PI3K inhibitor, you go to second generation, and now you go to more isoform specific. So what exactly do you mean by isoform specific? So we all know that PI3K includes the catalytic subunit. It includes the regulatory subunit. In the catalytic subunit, there are 4 isoforms. So there are 2 isoforms. This is a catalytic subunit. This is a regulatory one. In the catalytic subunit, you have 4 PI3K isoforms. Alpelisib is basically a specific inhibitor of a PI3K alpha isoform. So starting from the entire pan PI3K, you go down to dual. From the dual, you go on to a specific isoform, and this is the alpha isoform that basically alpelisib actually inhibits. So we are going and zooming in, like we are from MBBS to MD to DM, and there are certain people who do specialize in specific oncology. There are some stupid people who specialize in lung oncology from Rajiv Gandhi itself. So you're by and large, you are by and large concentrating on one particular subunit only. So what did the SOLAR-1 trial did? SOLAR-1 trial basically compared people who had progressed on an endocrine therapy, that who had received AI, were randomized between alpelisib and fulvestrant versus fulvestrant and placebo. So the standard of care arm basically was fulvestrant, and alpelisib plus fulvestrant versus placebo was compared. They also compared PIK3CA mutant versus PIK3CA non-mutant. So first, you look out for the mutation. If you are mutant, you will get alpelisib fulvestrant versus placebo. Even if you're this thing, you will actually get the drug, and then you will see what exactly is happening around over there. Very importantly, 90% of the patients had mutational status identity from the archival tissue. You know, in lung cancer, in other cancers, we always say we want the latest biopsy. But again, very important is you do not need the latest biopsy. 90% of the patients had mutational status from the archival tissue. The baseline characteristics were all very, very matched. Very important thing is that a lot of people had endocrine resistance, which was primary, which was seen in 27 or 13% of patients, and a secondary resistance. So by and large, both the groups had basically received were basically balanced. Prior CDK4/6 inhibitor treatment was there only in 6% in both the arms. So this is a point which is worth noticing over here. And this is the results which basically show, and look at the separation of the graphs. I always tell my residents, you know, that look at the separation of the graph. The graph actually starts separating very, very early. Within the first 1 to 2 months, you actually find out that the people who have got an alpelisib plus fulvestrant are actually doing well. The median PFS was doubled, 11 versus 5.7 months. The median PFS by the centrally assessed cohort and the locally assessed cohort was by and large the same. It had a high response rate also. A lot of people will tell, you know, we have an impending visceral crisis. So shall we give this or shall we give chemotherapy? The overall response rate, in fact, if you look over here, was 35.7%. With a single agent paclitaxel, you have around 40-45% in the second or third line. So you have a 35.7 versus 16.2. So that is also absolutely okay. Now, does this drug work only in PIK3CA mutant? So as a proof of concept, PFS in the PIK3CA non-mutant also was taken, and there was no difference in the cohort over there. So this drug is a very specific PIK3CA alpha isoform inhibitor and works basically in those. Any subgroup which did not benefit? No. Every subgroup basically benefited, whether you had lung mets, liver mets, bone mets, prior chemotherapy, primary resistance, secondary resistance, type of PIK3 mutation, whether the mutation was there by solid tissue or whether it was there by liquid biopsy. Every subgroup actually benefited from this treatment. Now, locally assessed PFS by tissue or plasma. You know, a liquid biopsy is very, very famous in lung cancer and other cancers. So should we go ahead and do a liquid biopsy? Should we go ahead and do a tissue biopsy? It does not make a difference. Whether you have a liquid biopsy or you have a tissue biopsy, the results are by and large the same. Your PFS is 11 and 10.9. So there is no difference. If you have a PIK3CA mutation, either archival tissue or latest tissue, whether on solid biopsy or on liquid biopsy, it does not make a difference. Your alpelisib plus fulvestrant is really going to act. This is just to again say that the majority of the sample used for PIK3CA screening in SOLAR-1 were from the primary tumors. They were not from the metastatic site. So initial biopsy report, absolutely no hazard whatsoever. So what changed in year 2020? COVID came. This is what everybody knows. What Novartis does not want to tell us is a lot with a capital T change in the year 2020. Because in the year 2020, this is what Novartis never wants to tell. The OS data of this trial was basically presented. The median OS was prolonged by approximately 7.9 months. However, because the OS analysis in this cohort did not cross the pre-specified O'Brien-Fleming efficacy boundary, they wanted one-sided P to be less than 0.0161, which did not cross. So numerical advantage of 8 months, but the statistical significance was not achieved. However, the OS by the subgroups, you know, the bad disease, look at the liver disease. If you had a patient with liver disease, this drug really works over here. with a median overall survival of 37.2 versus 22.8. This is the difference, that if used in the right patient, then that this drug actually can work. The time to first chemotherapy, again, the chemotherapy, even if you are sitting in AIMS or Tata or Rajiv Gandhi or the way where Priyanshu is practicing, nobody wants chemotherapy. Everybody wants to delay the chemotherapy, and a median delay of 8.5 months was observed for till the time to chemotherapy in the alpelisib plus the fulvestrant arm. So the conclusions were, there was a numerical OS advantage, 7.9 months. It was not statistically significant. However, patients with liver and lung metastasis derived greater benefit from this drug rather than the other one, and obviously it delayed time to first chemotherapy. So that was the conclusion which was given by the ESMO 2020. However, if it's too good to be true, there is something wrong. So this is there is something definitely wrong. It is not an easy drug. Let's be very honest about it. You cannot give it to, it is not a gefitinib, it is not a tamoxifen, it is not a letrozole, it is not a imatinib. This drug requires careful selection of patients. And why I am saying this is because the grade 4 AEs were there in hyperglycemia and diarrhea to the tune of around 12% and 4%. 25% of patients actually discontinued alpelisib, 18% for hyperglycemia, 9% for rash. It was basically discontinued. So this is what, I told you initially, the honeymoon was over. And even if the honeymoon was not over, the shadi has its side effects over here. So let's get practical. We know the drug is toxic, but isn't a dose dense AC Taxol toxic? Isn't bone marrow transplant toxic? Isn't some other chemotherapy toxic? Do we stop giving them? If there's a benefit, we select the right patient actually over there. So let's get practical about expectations. Let's see what exactly is going to come when we give PIK3CA. The first and the foremost thing which I ask my patient is about the history of diabetes. A lot of people will be diabetic, some of them will not be diabetics. A very important thing is to tell them that you will get diabetes, your sugars will go high. Now, why will your sugar go high? Because the insulin signaling through the PI3K drives the glucose uptake into the cell. So what happens is, if you have a PI3K cell over here, the glucose transport cells move up to the surface to drive the glucose uptake. If this PI3K is blocked, the glucose transport receptor will stay inside the cell. It will never go to the surface. Obviously, your sugar will high. So your sugar will raise. You tell the patient that this is a side effect, your sugar will raise. You have to monitor your sugar in the first 1 or 2 weeks. I'll come to that. A very beautiful article which was published in Annals of Oncology by Hope Rugo. What this basically said was, see, this is basically to show that everybody learns on the job. Initially on the Solar 1 trial, their HbA1c inclusion criteria was 8.5. They had huge toxicity. What they did was they reduced the criteria to less than 6.5%, and then it changed over there. Again, there were rashes. They gave prophylactic antihistaminics. It came down. They told the patient diarrhea was there. It came down after that. And the best point is the initial occurrence of both the higher grade hyperglycemia and rash were observed within the first 2 weeks of the treatment. So you should tell the patient. I always call my patient initially on the first 7 days, then on the 15 days, and tell them, please monitor your sugar. I give them a prophylactic anti-allergic, and I do not give it to people who have an HbA1c of more than actually 6. If it is 6.5, I tell them to meet an endocrinologist and then take treatment. It is not only enough to ask them to meet an endocrinologist, because people will maybe use insulin to start with. In fact, it is very important to monitor their sugar. Start with metformin. Start with metformin 500 mg, then put it 500 mg BD. Then you increase the dose. Doesn't make a difference, then you add an insulin sensitizer, that is a pioglitazone. Doesn't make a difference, then you use insulin. So it's very, very important for us as medical oncologists to know what exactly basically we are dealing with. Start with metformin, add pioglitazone, then add insulin onto it, and the side effect will be easy. Lifestyle change is very, very important. Ask them to walk and be exercise. Take a good diet, not a Punjabi diet that we all are supposed to take. The second most important thing basically is the rash. Now, I always again tell my patient rashes will be there, and I do give them a prophylactic treatment prior to the onset of rash. Do not wait for the rash to occur. I actually give them fexofenadine 180 mg. My prescription will include fexofenadine, antidiarrheal measure, regular BP charting, regular sugar charting. And this was a trial basically which said only 25% in the patient who got a prophylactic antihistaminics developed a rash, as against 65% of people who did not get. So tell them the sugar will get high, tell them to monitor their BP, tell them about the diarrhea, tell them about the rash, give them prophylactic antiemetics, and things will be absolutely okay. This is something which is very, very important. This is what the patient-related outcome basically was there. And what they basically found out was that the QLQ C30, that is the quality of life quotient, C30, global health status quality of life, was not different between the alpelisib and the fulvestrant versus the placebo and the fulvestrant arm. And this is exactly what was there in the SOLAR trial. So this actually came as a news to me. I mean, I was actually thinking the quality of life will become more worse with that. But no, it was not different between them. Alpelisib did not do this thing, because again, because partially the side effect, because alpelisib prolonged the PFS, that is why it was able to counter the side effects. Now I did show you alpelisib does in the SOLAR 1 trial, there were very few patients with CDK4 inhibitors. So what about the CDK4/6 inhibitors? That's somebody's got a Mona Lisa regimen. Will alpelisib work? So there's a trial which was published in SABC 2021, and this was the BYLieve trial. The first cohort over there is patients of 112 patients who have got CDK4/6 inhibitors plus AI as an immediate prior treatment. And again, here the PFS basically was 7.3 months. The 18-month PFS was 22%, almost similar to what we got in the SOLAR trial. The median OS of around 26.4 months. So definitely this drug acts even after you have given alpelisib, ribociclib or palbociclib. So to conclude, I would like to conclude basically by saying, I showed you a photograph of a lady who was greedy, I would say. So I would actually say, stay hungry, stay foolish. Greed, for the lack of a better word, actually is good. And the stay hungry and stay foolish is for new drugs for better overall survival. Greed is good for new drugs for a better overall survival. And with this, thank you. Thank you, Priyanshu, for the invite. It was lovely coming and meeting you after a long time. Thank you.